Welcome to USMLEFasttrack.com. The section we're going to talk about today is from First Aid for the USMLE Step 1, 2013 edition.
Page 424. Subdural hematoma. What causes subdural hematoma? Subdural hematoma is caused by rupture of the bridging veins. The bridging veins are just small veins that are underneath the dura mater, which drain the underlying neural tissue, and they puncture the dura mater and eventually empty into the dural sinuses. So these veins, when they're ruptured, they cause subdural hematoma. Describe the formation of hematoma and subdural hematoma. In subdural hematoma, there is slow venous bleeding, so there is less pressure, and therefore the hematoma develops over time. What group of patients are more likely to suffer from subdural hematoma? Subdural hematoma can be seen in elderly individuals, alcoholics, patients with blunt trauma, and shaken baby. Predisposing factor of this is brain atrophy, shaking, and whiplash injury. Describe what is seen in a CT in a subdural hematoma. In subdural hematoma, you see crescent-shaped hemorrhage that crosses the suture line. Crescent just means like the moon when it forms that C shape. Also in subdural hematoma, due to the pressure created, there is also a midline shift, but it does not cross the falx or the tentorium.
For more information on this topic, click on the link in the description section below. For a full USMLE Step 1 review, be sure to check us out at USMLEFasttrack.com, where we help you review the entire first aid for the USMLE Step 1 with high quality videos and hundreds of detailed pictures for a better understanding of the material. So to learn from the best USMLE review book, be sure to check us out at USMLEFasttrack.com.
Good evening, Rio Grande Valley. Tonight, we learn about one woman's experience with an intracerebral hemorrhage and how endovascular surgery changed her life. Marcela Perez is one of many Americans that suffer from an intracerebral hemorrhhage, an extremely common form of stroke where a blood vessel ruptures in the brain, causing bleeding.
The treatment options we offer is an endovascular approach. So basically we take these little tubes and go in through the groin and up into the blood vessels that supply the brain. And we go in and we navigate our wires and our catheters through the small vessels until we get to the vessel of interest. And then basically we use medical grade glue and shut down those feeders.
Dr. Hassan explains traditional treatment for such a condition would remove the affected portion of the brain, but doing this would have left Perez without any motor function on her right side and without the ability to speak.
The major causes for intracerebral hemorrhage is something we call an AVM, or an arteriovenous malformation, which is basically a clumping of abnormal blood vessels between the arteries and the veins.
The Valley Baptist Medical Center in Harlingen is the only facility south of San Antonio able to offer this latest technology.
I've been able to achieve the best possible outcome with the brain bleed.
Reporting on Health Matters, I'm Lissa Hansen.
Bob was really interested in the study to lower blood pressure in intracranial hemorrhage. It was a large international study, actually, 2,800 patients. And it was close but no cigars. They found on the primary outcome measure that there really was not a statistically significant difference. Yet I had the feeling that the authors thought that there really was a trend that was important and that they should be lowering the blood pressure. What's your reaction?
Well, my reaction is this is one, it's a really important problem of how do you manage blood pressure in the acute phases of an intracerebral hemorrhage when the blood pressure is really high. There's a real rational reason to try to lower the blood pressure acutely because we know that 25 to 30% of those patients will have rebleeding within the first 24 hours, and it's thought to be maybe due to high blood pressure. So the trial was designed to intensively lower blood pressure using intravenous medications compared to kind of the standard approach, and they actually achieved that. They reduced the blood pressure by about 10 to 15 millimeters of mercury in the intensive control group compared to the kind of routine management. And they did find this marginally significant outcome difference between the two groups, actually. Those that were randomized to the intensive control group actually had less bad outcomes defined by this Modaffin-Rankin scale compared to the the routine management group. But the statistical significance was right at the borderline, as you mentioned. But it was concluded that the primary outcome was not significant.
Well, maybe I'm being concrete, but they had a surrogate measure. They could actually look at the imaging studies, and there wasn't any difference in the two groups in the size of the hemorrhage. So what made these people get better?
Well, I think in truth, we don't know for sure. Maybe that, the lowering of the blood pressure, if in fact it was beneficial. And let me just emphasize, actually, the primary outcome was the proportion of patients who were moderately disabled or worse. So moderately disabled, severely disabled, or had died. And the proportion of patients who had that bad outcome were 4% less, so 52% of patients actually achieved that outcome compared to 56% of patients. So there was an absolute difference of about 4%, and that was only marginally significant. Well, actually wasn't significant, but marginally. But on all the other measures, it was all trending in the right direction. So they looked at that outcome measure in various ways, pre-specified, and that also was actually marginally significant. They also looked at quality of life measures, and actually in the scales of the quality of life measures, all the actual measures were trending towards significance in those patients who had survived. So I think we may not know actually how intensive blood pressure, it may not be that it's acting through direct reduction of blood volume of the hemorrhage, but it may be acting in other ways, and I'm willing to accept that we may not know all those ways. But in fact, it looks like it's very close to being significant on very important outcome measures to patients, and that's severe disability or death.
So the next patient that comes into your intensive care unit when you're the doctor and they have an intracranial hemorrhage, are you satisfied enough with this study that you're going to bring the blood pressure down, or are you going to wait for the results of another study?
Well, that's a great question, actually. I actually think I am going to be a little bit more willing to aggressively treat blood pressure than I have been in the past. Now, I don't know the right measures, and I don't want to say 140 versus 150, 160. I think we can't be so concrete about the numbers either, but I think my tendency to want to control blood pressure will be a little bit more sensitized because of the results of this study. And when in doubt, I may favor more aggressive treatment and starting IV the therapies, even given all the caveats out of this study that it was done mostly outside of this country. It was using medications that we normally don't use. But it just makes so much sense to me, actually, that this mechanism may work and that the trend of a very important outcome is in that right direction, that I would be more inclined to just tip over and maybe start using it a little bit more liberally in patients. After all, one of the important findings of the study was that intensive blood pressure lowering was safe. Actually, it wasn't fraught with adverse events or higher incidence of adverse events. So we know it's safe, the trend's in the right direction, and it's an outcome that is amazingly important in patient center, that is severe disability and death.